quick look at our agenda. We are following the exact flow of a surgical team in the OR. Prepping and draping, incisions and access, wound healing and sutures, and finally, suturing techniques and timelines.
All right, Section 1, Prepping and Draping Protocols. This right here is the true infection battleground. The absolute first rule, before a blade even comes close to the skin, is a strict foreign body alert. All rings, all watches, they have to come off. And it's not just about infection control, it's to literally eliminate the risk of thermal burns and absolutely catastrophic digital vascular compromise.
Now, you might have seen the old trap of shaving a patient on the ward the night before surgery. Well, scratch that. Traditional shaving actually creates these tiny microabrasions that bacteria just love to colonize overnight, shooting cellulitis and infection rates through the roof. The evidence-based right way? Hair should really only be removed if it's in the way of the incision. And when you do have to remove it, use skin clippers with disposable blades right there on the OR table and only after prophylactic antibiotics have started running.
Let's talk antisepsis mechanics. The absolute gold standard solution here is alcohol-based, specifically chlorhexidine alcohol. And you've got to think ahead. Spatial planning for things like main incision extensions, port sites, or drains is a must. Oh, and for abdominal cases, always grab a slender cotton swab and deep clean the umbilicus first. Then, it's all about direction. For a clean wound, you start at the incision site and paint outward in concentric circles. But if it's contaminated, you reverse that logic. Start at the cleanest area and work your way toward the mess so you don't spread the bacteria. And guys, this is huge. You absolutely must let that solution dry completely. Pooling liquid under a patient is a severe, immediate fire and chemical burn hazard waiting to happen.
Moving on to Section 2, Incisions and Abdominal Access. This phase is all about mechanical precision and patient safety. For example, direct hand-to-hand passing of a scalpel, totally forbidden. You always use a designated neutral zone, like a kidney dish, to prevent any sharp injuries. And when that scalpel is finally in your hand, burn this number into your brain, 90. The 90 degrees scalpel rule. You have got to hold the blade firmly at exactly a 90-degree right angle to the skin and draw it smoothly. If you tilt it to make an oblique cut, you create a shearing mechanism. That shearing causes tissue necrosis on the undercut skin edge, which means you've severely compromised the wound before you've even finished the operation.
Picking the right blade shape is just as crucial as how you hold it. The source breaks this down into 3 primary styles. First, the size 10 or 22. These are curved, and they're basically your workhorses for long skin incisions. Next up is the size 11, which has this incredibly sharp tip. It's exactly what you need for precise punctures, like arteriotomies or drain insertions. And finally, the size 15. This one is tiny and strictly reserved for minor, highly delicate surgical work. Matching the right blade to the tissue is a fundamental part of surgical mechanics.
Got another number for you? 3. When you're cutting out a circular lesion and want minimal scarring, remember the 3 times length to width ratio for elliptical incisions. To guarantee a nice, tension-free closure, your ellipse needs to be at least 3 times as long as it is wide. If you ignore this, you're going to end up with a dog ear, a really annoying, visible pucker of tissue at the ends that you'll just have to hook and cleanly cut out anyway.
Let's walk through a super versatile, rapid access protocol, the midline laparotomy. It's a very precise 5-step execution. Step 1, incise the skin using the xiphisternum, umbilicus, and pubic symphysis as your visual map coordinates. Step 2, dissect through the fat to expose the white linea alba. Step 3, incise that linea alba longitudinally, making sure you stay super close to the umbilicus to avoid those vascular rectus sheets on either side. Step 4, cleanly pick up the peritoneum and make a safe little nick with your scissors. And Step 5, this is vital for safety, insert 2 fingers into the cavity to physically shield the bowel underneath while you extend the cut. It's like a built-in safety guard.
All right, Section 3, Wound Healing and Suture Selection. We're shifting gears from access to closure now, starting with the actual biology of how wounds heal.
First up is primary intention. This is the dream scenario in surgery. The wound edges are cleanly opposed and brought perfectly together. The result? Super fast healing and a really minimal scar.
Then we have secondary intention. This happens when the wound just can't be immediately brought together. It's essentially left wide open, and the body has to do the heavy lifting from the bottom up. It does this by forming granulation tissue, contracting the wound, and finally epithelialization across the surface.
And the third modality is tertiary intention, or delayed primary closure. This is a very strategic delay used specifically for highly contaminated sites. You purposefully leave it open for a few days to let the infection clear out, and only then do you go back in to surgically close or graft it.
So understanding how a wound heals completely dictates the structural architecture of the suture we pick. Take monofilament sutures, like polypropylene. They are stiff, with high memory, making them a bit harder to knot. But their smooth surface means a super low infection risk because bacteria have literally nowhere to hide. Just be careful. They are highly vulnerable to fracture if you mistakenly clamp them with a needle holder. On the flip side, multifilament or braided sutures, like silk or polyglactin, handle like a dream with great knot security. But they carry a massive infection risk. Their braided capillary surface allows bacteria to lodge deep inside and cause chronic sinuses. And a major pro tip, natural non-absorbables like silk will fragment over time. So no way, never use silk for vascular anastomoses or you risk late fistula formation.
Now let's look at needle anatomy. First rule of grip, always hold the needle about 1/3 of the way back from the rear shank, never clamp the structural shank itself, and definitely don't clamp the delicate tip. Next, you have to match the needle point to the tissue. Round-bodied needles taper to a fine point, gently pushing fibers apart rather than cutting them, perfect for soft, delicate stuff like bowel or vessels. Cutting needles have sharp triangular edges meant for dense, tough structures like skin and fascia. And blunt-ended needles? You absolutely want these for mass abdominal closures because they practically eliminate the risk of needle stick injuries for the surgeon.
Okay, the final stretch, Section 4, Suturing Techniques and Timelines. Let's see how we actually execute these final closures.
We've got 4 major stitches to master here. First, the interrupted stitch. This one follows a really strict geometry rule. Your distance from the entry point to the edge has to equal the depth of your bite, and you space them exactly twice that depth distance apart. Second, the continuous stitch. It's fast, keeps steady tension, and you lock it at the end with an Aberdeen knot. Third is the mattress stitch. Vertical or horizontal, this is brilliant for irregular wounds because it guarantees accurate edge alignment and forces the tissue to properly evert or turn outward. And finally, the subcuticular stitch. By taking alternating bites just under the skin plane, it leaves absolutely zero external railroad scars. Pure magic for aesthetic areas.
All of this builds to one of the biggest paradigm shifts in abdominal mass closure, moving from big bites to small bites. The old way was all about big bites, stitches a full centimeter apart, a centimeter deep, using thick number 1 PDS suture. The problem? Those big needles punch buttonhole defects, and under tension, it acts like a cheese wire, eventually loosening the fascia. The new evidence-based standard is small bites. We're talking just 0.5 centimeters apart and 0.5 centimeters deep, using a thinner 2.0 PDS on a narrower needle. This incredibly precise mechanical change, it drastically reduces the incidence of postoperative incisional hernias, a total game changer.
And finally, the clinical timeline for suture removal. It's a delicate balancing act, right? Pull them too late and you get permanent tracking scars. Pull them too early and the wound dehisces, bursting open. For the face, removal happens fast, between day 3 and 5. For the neck, it's day 5 to 7. And the abdomen? You've got to wait a solid 10 to 14 days.
Wow, we've covered a tremendous amount of ground in this explainer today. We've gone from the absolute necessity of safe surgical site prep and precise 90-degree scalpel mechanics, right through the biology of wound healing, all the way to the paradigm-shifting small bites technique in abdominal closure. So I'm going to leave you with this thought. How will strictly applying these rigid, evidence-based mechanical adjustments directly elevate your own clinical practice and your patient's recovery rates? Think about it. Thanks so much for joining me for this explainer, and keep learning.